Hello, I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncologist. And we're talking today about colon cancer. And joining us is Dr. Chen, who is a medical oncologist and hematologist at GBMC. Dr. Chen, thank you so much for being with us today.
Happy to join you today.
So we're talking about colon cancer and maybe some colorectal cancer as well. And we have a whole list of questions from people who are joining us on this conversation. And so I'm just going to go through them and start really broadly and talk about what is considered colon cancer.
Sure. Colon cancer refers to the disease arise from the colon, including the right side of the colon and the left side of the colon. And typically, we made the diagnosis through the colonoscopy, and by which the suspicious lesion is biopsied and reviewed by the pathologist.
How common is colon cancer when you're looking at all cancers?
Colon cancer is considered as a common disease, and according to the WHO database, colon cancer is the third most commonly diagnosed cancer in men, and the second most common cancer in women. And roughly, the lifetime risk of having colon cancer is 4%. And so approximately over 100,000 cases, new cases diagnosed in the United States each year.
And is this because the screening is so good?
Yeah, absolutely. Screening play a role. And colon cancer, the median age at diagnosis used to be like 72 back to 20 years ago. Now came down to 66 due to the screening, due to the awareness.
Wow, that's quite a drop. And also, we were just talking off camera before we started talking now in this conversation that even younger people are being diagnosed at record rates.
Absolutely, yeah, that's absolutely right. So we do see more and more young patients diagnosed with colorectal cancer, and the etiology is still unknown, but the possible theory including number one, diabetes, number two, obesity, number three, genetics changes, and number four is most interesting part is that microbiome. We have like 1 trillion bacteria in our body, and scientist is working on this to find out which bacteria may cause the colon cancer.
That is interesting. So does that mean that something that we're consuming as a population is increasing possibly a certain bacteria that is leading to an increase?
That is a possible etiology, but at this moment, we don't know yet. But there is a chance that in the future, we can analyze the bacteria, and we recommend like, hey, you should go for the colonoscopy at the age of 40 instead of 45, or you should even have the colonoscopy even earlier.
Okay, so that takes us to one of our questions, and you just alluded to it. What is the proper age for your first colonoscopy? Let's say you have no family history that you know of and no symptoms.
Right, this is considered like average risk population. American Cancer Society recommended to start screening at 45. And the U.S. Preventive Service of Task Force also recommended the same age. They updated the guideline last year.
And what about if you have a family history?
So family history here referring the first degree relatives. So that means the parents, the sibling, and the child. So grandpa, grandma doesn't count as their family history. And for patient have first degree relative history of colon cancer, if the diagnosis was less than 60, we recommend to start screening at 40 instead of 45. And if the relative's age, diagnosed age is over 60, we still recommend start the screening at 40. But later on, if the first initial screening is normal, then we can just repeat the colonoscopy every 10 years. But for patient have a first relative age less than 60, and we recommend to do the colonoscopy every 5 years.
So what if you don't have a family history and at 45 you get a colonoscopy and they find, I don't know, precancerous polyps, let's say. That could change the spacing of your next colonoscopy?
Correct. And based on the histology of the polyps, polyps have two groups polyps. One is neuroplastic polyps, and the second group is non-neuroplastic polyps. And if it's just the inflammatory polyps, it has been known that not associated with cancer. So we just do it every 10 years. But if there's neuroplastic polyps, we recommend do the colonoscopy based on the number and based on the size of the polyps. Let's see if the patient have 3 polyps, probably we would recommend repeat the colonoscopy in 5 years. And if it's 5 neuroplastic polyps, we recommend repeating in 3 years. And if there's 10 polyps, we would recommend repeat the colonoscopy in 1 year.
Let's put the fear of a colonoscopy at rest for some people. I think there's a preconceived notion that it's horrible, that the prep is terrible, people put it off for long periods of time, but the prep process has improved over the past several years, has it not?
Yeah, I think so. When I was training, you have to drink like 4 liters ball prep, but now I was told just a Gatorade bottle, 2 bottles, and start a liquid diet 1 day prior to the colonoscopy. Much easier than before.
Yeah. And then you come right back afterwards. It's not that big of a deal and so important. So you touched on this a little bit, but could you talk about who is most at risk for colon cancer?
Sure. So the major risk factors for colon cancer are number 1 is a certain hereditary form of disease. Number 2, family history of colon cancer. Number 3, inflammatory disease, bowel disease, such as Crohn's disease or ulcerative colitis. And number 4, the age certainly is a risk factor. And lastly is previous abdominal radiation.
And how is colon cancer diagnosed primarily?
Right, so for the most part, the diagnosis is made with the colonoscopy. And through the colonoscopy, the gastroenterologist will remove the suspicious lesion, and the specimen will send it to the pathology to be reviewed. And basically, will be diagnosed based on how does it look under the microscope.
Let's say we're too young for a colonoscopy or we're between colonoscopies and we get symptoms. What kinds of symptoms could present themselves if a cancer does develop?
Yeah, great question. There are a variety of symptoms associated with the colon cancer. People can have like a dark stool, blood in stool, can have bowel habit changes, can be from the diarrhea to constipation or vice versa. And sometimes patients present with abdominal pain, abdominal distension, unexplained weight loss. And I would recommend if any symptoms persist over 2 weeks, the patient should seek medical attention.
Yeah, because those are symptoms that could mean a million different other things, right?
Right, exactly. And sometimes there's no some symptoms whatsoever. So that's why we recommend the screening for everyone.
So what are the treatments once, and I'm sure they can vary greatly between patient to patient, but what are the treatments available for someone who's been diagnosed with colon cancer?
Right, depends on the stage and the location. And for early stage of cancer, the colon cancer, I would say 75 to 80% of the chance colon cancer is diagnosed with a localized disease. Basically, the cancer limited to the bowel and nearby lymph nodes. And for the localized colon cancer, the surgery is a primary treatment. And the surgeon can take off the tumor and remove the vascular pedicle and also remove the lymph node drainage. And for the stage 4 colon cancer, the treatment would be a little bit complicated. And back to like 20 years ago, we only have one drug available. It's called 5FU. And nowadays we have over 10 drugs available, and the outcome has changed significantly. And we have a better understanding of the carcinogenesis, which is the process of the cancer development, and also the advances of genetics. We are able to further characterize the tumors at the molecular level, so we can consider the immunotherapy, targeted therapy.
When it comes to location of colon cancer, it really matters where it is, doesn't it?
Yeah, it does. This is a great question. So colon cancer, we used to consider colon cancer as one disease. But nowadays we realized actually the right-sided colon cancer and the left-sided colon cancer are different. So the right-sided colon cancer, referring the colon cancer arises from the cecum, ascending colon, the hepatic fracture, and also transverse colon. And the left side colon cancer refers to the rest, including the descending colon and the sigmoid colon. And the right side of the colon cancer, in general, consider have a worse prognosis and most commonly seen in elderly patient and also seen in female.
Okay, I want to get to some of these questions because people did ask them and they really want to hear the answers to them, and time is of the essence. So someone wanted to know, is Cologuard an appropriate test to determine if colon cancer is present?
Cologuard is a stool DNA test. I would say in terms like colon cancer detection, Cologuard has the sensitivity of the 92%. That means Cologuard can miss up to 8% of the colon cancer diagnosis. But in terms of like the preventative aspect, Cologuard is less than half as effective as colonoscopy. So colonoscopy absolutely is a gold standard and has the higher likelihood to detect the cancer, and also can be preventative, can remove the suspicious lesion and prevent the polyps from turning into the malignancy.
What are some immunotherapies available for colon cancer patients?
Sure, immunotherapy has been quite popular over the past 10 years, has been approved in lung cancer, melanoma, esophageal cancer, and kidney cancer. So immunotherapy is one of the cancer treatment, basically to help the immune system to fight off the cancer. And the immunotherapy has been approved in a subset of colon cancer. There is about 15% of the colon cancer has microsite instability, or we call the deficient DNA mismatch repair. And so normally, the cells is able to fix the error or mistake during the cell division, but sometimes the cells is not able to fix it, and this is called DNA mismatch repair. And for this population, and immunotherapy has demonstrated a good efficacy and a durable efficacy, and is much better than the conventional chemotherapy.
How does treatment affect a patient's day-to-day life? And I'm sure people get concerned about the idea of a colostomy.
Right. So during the colon cancer is a life-changing event. And sometimes we also, before we start the treatment, we would like to know who is likely to tolerate the treatment well, who is unlikely to tolerate treatment well. And we do have the risk assessment tools to predict based on patient daily activity and nutrition status and psychological status and also comorbidity. And in general, for patient have a good performance status, means patient is able to walk independently, continue to work, we will see likelihood the patient is able to tolerate treatment well. And in general, younger patient tolerates the treatment better than the older patient.
Are there times when the treatment can you reverse a colostomy?
Correct. Yes, for curative intent, like a stage 3 colon cancer, after patient received the chemotherapy, and we stage the patient with a CT scan. If there's no evidence of recurrent disease, yes, our colorectal surgeon will reverse the colostomy.
Once a person has completed treatment, do they require any special or additional screenings?
Great question. We do recommend to have a surveillance follow-up. We recommend to have blood work, physical exam, and a CT scan periodically based on the stage of the cancer. And also, we recommend to have a repeat colonoscopy 1 year after the surgery. And the first colonoscopy be followed like 3 years or 5 years later based on the findings on the colonoscopy. And the purpose of this surveillance is to pick up if there's any early recurrence or if there's any secondary primary, so we can easily remove it and increase the cure rate.
Someone wants to know more about chemotherapy. Is chemotherapy always used or often used after a colon cancer diagnosis, and what is the benefit of it?
Great question. Chemotherapy is recommended for high-risk stage 2 disease and also for all the stage 3 colon cancer. So during the cancer development, there is some cancer cells, colon cancer cells, they can escape from the original tumor site. And when the tumor is too small, we cannot even identify the tumors on the CT scan. And so the role of the chemotherapy is to eradicate this microscopic metastasis and to increase the chance to be cured. And let's see, for the stage 3 colon cancer, after the surgery, basically about 50% the chance patient will be cured. But with the post-operative chemotherapy, we can increase the cure rate to over 70%. So about like 20% additional benefit.
Do you have any tips to prevent colon cancer? Are there things, lifestyle choices that we're making that we know increase the risk?
Yes, exactly. So there's some modifiable risk factors associated with colon cancer. such as diabetes, um, obesity, the excessive consumption of red meat, and the excessive consumption of alcohol, like smoking, and also the lack of physical activity. So it has been proved that routine physical activity, like 30 to 60 minutes a day, would be beneficial to decrease the risk to have recurrent colon cancer, and decrease the alcohol drinking. Like it has been also demonstrated that even small amount of alcohol drinking can contribute to breast cancer, colon cancer, and stomach cancer.
What is a perennial fistule?
Yeah, that is refers to the abnormal opening in the rectal anal area. And usually patient presents with the non-healing opening with drainage. And the surgical management would be the mainstay of the therapy. And we have excellent surgeon at the GBMC, Dr. Darago, Dr. Flores, and I would recommend the patient to see colorectal surgery for the evaluation.
I was wondering, now that we're well into 2 years of COVID, have you seen people who did not get their colonoscopies during 2020, maybe even 2021, or put it off? Are you seeing any of an increase in colon cancers?
Yeah, over the past 2 years has been challenging for everyone, especially for our patient. At the beginning of the pandemic, I have seen patient with a delayed diagnosis. But things has changed since the vaccine is available and the patient does not have fear to come to the hospital anymore. The other thing I would like to comment is that for patient have colon have the cancer, especially for patients on chemotherapy, does have a higher risk to have COVID-19 infection, and it does have a risk to have a serious infection. And most recently, FDA approved, not approved, is initial emergent use for 2 antibodies. One is for post-exposure, and one is for pre-exposure antibody. And we started sending patients to receive the antibody treatment that can prevent from severe COVID-19 infection.
Can you talk about, and this is from the heart too, what makes the Sandra and Malcolm Berman Cancer Institute and the whole team at GBMC stand out in your mind?
Sure, we have excellent team, including the colorectal surgeon, excellent gastroenterologist, interventional radiologist, and radiation oncologist. And we probably see more patients than other community hospital in Maryland. And the patient continue to choose us because the quality of care and our reputation and our supportive service. So we have a strong oncology support service, integrative medicine, and also we have clinical trial opportunities. We offer clinical trials for a variety of cancers, including the colon cancer. And our cancer institute is growing, and we are going to have a new cancer building in the following 3 years.
Yeah, everyone's going to be welcoming that when it's finally done. And speaking of that, and also raising money and raising resources, how important is the community, their involvement, their support to what you do?
Right. Yeah. So many of our supportive program, like the oncology support service, integrative medicine, and also we have hereditary cancer program as well. And all these programs require the philanthropic support to benefit our patient. And donation is one way. And also we have the volunteer program throughout the whole hospital. Yeah, and the donation can update our system and also the space renovation.
Yeah, it's all kinds of ways to help. Dr. Chen, before we let you go, we had one other question that just kind of came in under the wire, and I wanted to make sure that we got it in for you. The question is there a different screening protocol for, I'm assuming, colon cancer, for someone who has had prostate cancer and radiation, and the radiation was near the abdomen?
Yeah, so this patient would be considered a high risk. So the current guideline recommend to start a colonoscopy screening 5 years after the radiation.
Okay.
And based on the initial findings from colonoscopy, we can decide what's the when would be the next one. But in general,
It's
we
the same
recommend-
protocol.
Yeah, we recommend more frequent because this is considered like a major risk factors for colon cancer.
All right. Dr. Gang Chen, thank you so much for joining us today and giving your insights and your expertise on colon cancer and answering everyone's question. And we appreciate everyone for joining us today on Ask the Oncology Expert at GBMC.
Thanks for having me today.